ஆகவே இதுதான் என்னை நினைத்து பெருமிதப்படும். என்னுடைய 2000 என்னுடைய ஆளுநர் விருதுகளை எனக்கு 2010 நான் கவர்னரா இருந்த அதற்கு அடுத்த ஆண்டு நாங்கள் பேங்காக்ல போய் ரோட்டரி இன்ஸ்டிடியூட்ல நிறைய விருதுகள் வாங்கினோம். அது எனக்கு என்னெல்லாம் வாங்குறது இதை விட அதெல்லாம் எதிர்த்து எனக்கு தெரியாது. ஆனால் இப்பொழுதும் பசுமையாக இருப்பது வந்து யாருடைய வாழ்க்கையிலும் ஏதோ என்னால முடிஞ்சத ஒரு காரியம் செஞ்சிருக்கோம் அப்படின்னு நினைக்கும் போது அதை விட பகுதி ஏற்பதில்லை. அப்படித்தான் நீங்கள் உங்களுடைய வாய்ப்புகளை மிக முக்கியமானது. நம்ம வந்து ஒரு இலக்கை வைத்து நடக்கும். இலக்கு இல்லாம போகும். சென்னையில வந்து இருக்கிற கோயம்பேடு ஆசியாவிலேயே மிகப்பெரிய
என்ன பண்றது வீட்டுல வந்தாரு அலுவலக அம்பா
Allante.
Good evening. Are we ready to start?
Yeah, good evening, Aparna. Good evening. Yeah, can we start?
Yes, yes. Shall we start?
1 minute, 1 minute. Nilesh?
Yes, sir.
Can you start, Nilesh?
Yes, sir. We are ready, sir.
Just 2 minutes. We'll start in 2 minutes. Okay, Nilesh, we'll start.
Yes, sir. So we'll start with Tamilthai Vazhathu, sir.
Yes. Okay.
I request others to mute. Aman sir will start.
Okay, we'll go with IMA prayer.
Yes, sir. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of child, I rely on thee. Thank you. So followed by flag salutation.
Is Narmada joined?
Yes, sir. I've joined, sir.
Okay.
Flag salutation.
1 minute. Can you see the screen?
So yes, sir, but I'm seeing the YouTube only. Sir.
Okay. Yeah, it's a flag salutation. Narmada, please go ahead. The Vice President.
Sir, I'm not seeing that one, sir. You can stop share and again reshare, I think, sir. Yes.
Can I say now?
Flag salutations. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Followed by welcome addresses. President, IMA Vellore, Dr. Madan Mohan, sir.
Good evening to one and all. It's indeed a great meet between an IRIA subchapter of Vellore and IMA Vellore. For both, I'm a part of. I'm a member of both the associations. I'm very happy to take this topic amidst the COVID. Very challenging after the second wave. We should know when should CT be taken for patients with suspected COVID? No better than Department of CMC is better equipped to say the reasons for CT scan during COVID. So I a warm welcome to the speaker, Leena. I also welcome the president of Vellore Subchapter, Dr. Kanagarameswar Kumaran, secretary Dr. Pavitra Mannan, and the treasurer Dr. Aparna to this day, and all welcome to all the members who are joined in our Zoom link and on YouTube. We have crossed more than 100 participants as of now. Kumaran is here. Kumaran sir, you can give a warm welcome on behalf of IRIA Subchapter Vellore. So if he is not there, Nilesh, what is the next agenda? We'll go on to that.
Sir, we'll go to secretary report, sir.
Yeah.
So we know that. Good evening, all. Dr. Nilesh T, Secretary Vellore IMA. So as we all know, the last IMA program, which was live, was our COVID Warriors recognition program. After that, the COVID has started into peak. So apart from that, we have started our own IMA project, as you all aware. So in collaboration with CMC and VIT alumnus, IMA Vellore is supporting to reduce the panic of in and around people around Vellore to reduce the pandemic and support the panic situation and reduce the stress among the Vellore people. And it was taken forward by our President Dr. Madan sir and Vice President Dr. Narmada ma'am, along with Thrive Digital. So we are doing good over there, and a lot of people, we have nearly reached around 2,000 calls. So I thank all the members and volunteers supporting for the program. Thank you so much, and we'll go on to the next agenda. Introduction of the program by Dr. Aparna Shyam, Department of Radiology, CMC Vellore.
Good evening and welcome to everybody. There is a lot of confusion regarding when to CT in COVID. There are so many terminologies like CORADS, COVID RADS, CT severity scoring, so many different scoring systems. So we thought of clarifying at least some of these doubts forum during this webinar. I will now hand over to Dr. Pavitra to introduce the speaker.
Madan sir, can you mute the others? There's a lot of disturbance. Sharath, Dr. Sharath.
Yes, I muted. Pavitra, you can unmute and talk.
Good evening, everybody. I wish you all a good evening again. This is my pleasure to introduce to you the speaker for this evening, Dr. Leena. Dr. Leena is a professor and a member of the faculty of the Department of Radiology. Her specialty is chest radiology, and she has played a key role in formulating guidelines for chest CT in COVID setting in the country. So without further ado, I would request her to share her expertise and thoughts on the subject. Over to Dr. Leena.
Good evening, all. Is the screen visible?
Yes, ma'am, it's visible.
Yes, Leena.
Okay, once again, a very good evening. And I want to thank the office bearers of the IRIA Subchapter Vellore and also for the IMA Vellore for giving me this opportunity. So the next few minutes, we will look at what are the indications for doing the chest CT in COVID-19. And also, as Aparna mentioned, the various terminologies, CORADS, what does it indicate? And also to look into the CT severity score and how it helps in the management of the patient. Ever since the first publication came regarding the clinical and imaging features of patients infected with COVID-19, which was first published in Lancet in January 24, 2020. There were so many hundreds of articles have been published in radiology regarding COVID, and much more in the other clinical specialties also. Now, in April 2020, the Fleischner Society had brought out this multinational consent statement regarding the role of chest imaging during COVID pandemic. And they have looked at 3 scenarios, that is mild and moderate to severe when there is no resource constraint, and also moderate to severe in resource constraint. Now, this is a time when there was peak in the first wave of epidemic happening in the US and in the Europe, and also started in the Asian countries like from China, it has moved to India also. So they have looked at both in resource constraint as well as in the no resource constraint. And so in the mild, what they have mentioned was imaging is not indicated for diagnosing unless there is a risk factor, but whether or there is risk factor in whenever there is disease worsening, the imaging was indicated. And again, in the moderate to severe group, they have mentioned to use it even for diagnosis and also when there is worsening of the disease. And when there is resource constraint and when there is high test probability of having COVID-19, again, no matter what the RT-PCR result is, imaging was indicated and also in the disease worsening. So this is what their guidelines say. And ACR at a similar time has also brought out their stand on the imaging. And what they mentioned is CT should not be used to screen as a first-line test to diagnose COVID-19. It should be used sparingly and reserved for hospitalized symptomatic patients and with specific clinical indications for CT. And we should make sure we should have the appropriate infection control procedures, because the main worry about bringing the patient down to CT scanner is also the risk of transmission. Now, we all have seen that when the second wave started in India, there were unnecessary CTs being done in certain parts of country, in certain metropolitan cities, and this was causing much strain to the already strained healthcare system. And this was the background in which this white paper from Society of Chest Imaging and Intervention was brought out to bring the indications of CT chest in 3 specific scenarios, that is in diagnosis, in management, and in the follow-up. So in the diagnosis, moderate to severe symptomatic patients suspected to have COVID-19 for quick triage. Now, again, remember this white paper is sent out for the entire India, looking at smaller centers, scan centers, teaching institution, tertiary care centers, as well as secondary or rural healthcare. So this is a common indications, but there can be a little bit variation. Suppose in a setup where there is not much resource constraint, everyone with moderate to severe will get admitted no matter what the CT says, then you don't have to go for a diagnosis. So whenever there is a resource constraint and to triage the patient, moderate to severe symptomatic patients can undergo a CT chest. And asymptomatic to minimally symptomatic patients only when RT-PCR testing is not available or if the results are delayed by more than 48 hours, and the delay will change the way the patient is managed. And another scenario is when there is high clinical suspicion but the negative RT-PCR test, and again the CT finding favoring COVID will make a difference to management, whether it's starting with isolation, starting the treatment, and so on. And other unique situations are, suppose if a patient had waiting for an emergency surgery, say bowel perforation, the patient cannot wait for very long to get the RT-PCR test. So if that is not available or if there is a delay, and that delay will change the management, especially in very emergency situations, then we can do a CT chest. However, routine use of CT scan as a pre-admission or pre-surgical test in non-emergency situations is strongly discouraged. Coming to the management, CT scan is not indicated for routine management of patients. There is no need to do a scan at day 0, day 3, day 6, day 9, or even at discharge, as it's practiced in certain centers, which is not needed because it's not going to change the management decision. So key thing we have to remember, whenever we do CT chest, the referring clinician and the radiologist should ask the question, is it going to change the management? If so, we will do it. So it definitely helps to understand the extent and severity. And when there is disease worsening, that is also another scenario, we should go ahead with the CT chest. Now coming to follow-up of the scans, a follow-up of the patients. There is no need for routine CT during follow-up. So when do we do the CT? Only when patient is not improving, patient is having persistent dyspnea, the oxygen saturation levels are still low, and if the pulmonary function test is showing abnormality and it's persisting, then we should do the CT chest. Again, though in certain centers we have the facility of dual energy CTs, it is not in a clinical practice to do for every case. We have to have when it is to be done, and unless there is a strong clinical need, we needn't do it. So over the past 1.5 years, we found that the CT chest, initially, if you look at all the articles published from China, they have shown how the CT chest is higher in higher sensitivity, or in other words, it's superior to RT-PCR, or it can be used as an alternative diagnosis. That is how a lot of articles have come out, which is true. But is that required? Do we do CT chest? We realize that over the time, it is not needed. It has only more limited role based on specific indication. And the key thing we should ask ourselves is it going to change the management? How is it helping in the decision making? Now, earlier in March 2020, the RSNA, the Radiologic Society of North America, in the consensus statement endorsed by the Society of Thoracic Radiology and the American College of Radiology, had brought out 3 categories or 3 different morphological appearance, that is typical, indeterminate, and atypical. So what are the typical appearance? I know the radiologists here in the group may find it a little boring because you would have been seeing it day in and day out during this past 1.5 years, but for the benefit of everyone, I'll just go through it. So peripheral bilateral ground glass opacities with or without consolidation or visible interlobular lines, that is a typical crazy paving pattern, or multifocal GGOs of rounded morphology with or without consolidation, like how you can see here. And here you can see the ground glass with interlobular lines. And also you can see the reverse halo sign when there is consolidation with surrounding ground glass opacities. These are thought to be in the typical appearance of COVID. And what about the indeterminate appearance? When it is multifocal, or whether it is a little diffuse, more of perihilar, or when it is unilateral, those distributions are considered as, those kind of morphological appearance are considered as indeterminate. And what about atypical appearance? Like our typical garden variety lobar or segmental distribution, what we see in a bacterial pneumonia, or the tree in bud, like how we see in TB, those are considered as atypical appearance. Now, soon after the RSNA has brought out these typical and atypical and indeterminate appearances for COVID pneumonia, the Dutch Radiological Society had brought out this CORADS, which is something very commonly used in India, though as much as it helps the clinician to come to diagnosis, it has also created enough confusion. So CORAD stands for COVID-19 Reporting and Data System. You all would have heard of BIRADS, LURADS, LIRADS, TIRADS. So it's something in that similar terminologies, COVID-19 Reporting and Data System. So what are the different categories? So we have 0 to 6. 0 is not interpretable, and 1 is when it is very low. So what does that very low suspicion means? Whether when the chest radiograph is, chest CT is normal, or if there are features of lung tumors or fibrosis. So remember, even tumors will come under the very low category, or it is CORADS 1. And when the suspicion is low, that is, the features are typical for other infection, but not COVID, like the tree in bud, like how we see in TB, or the lobar or segmental consolidation. And what about CORADS 3? That is equivocal. So it is compatible with COVID, but it can be seen with other disease, that is the perihilar GGOs or GGOs with interlobular sepal thickening, which can be seen sometimes with interstitial pulmonary edema. And high suspicion is, that is, the features are similar to category 5, but it will be unilateral, or it may be not fully subpleural or peribronchovascular. And what about very high? That is a category 5. That is a typical for COVID-19. So that is similar to what I have, the same wordings, what I have mentioned in the RSNA statement, that is GGOs plus, or GGO is ground glass opacities plus or minus consolidation and multifocal subpleural. And they've also told about it is often seen adjacent to the fissures. And now if we put the CORADS category, that is 0 to 6, and the RSNA category, so 1 is negative for pneumonia according to RSNA. 2, CORADS 2 is similar to atypical appearance for RSNA similar to RSNA statement. CORADS 3 is corresponds to indeterminate category for RSNA, and 4 is again indeterminate, and 5 correlates with the typical pattern mentioned in the RSNA statement. So there is, both goes side by side. Now, in India, this CORADS system is something quite commonly used across the country. Now, as I mentioned earlier, sometimes these gives a little confusing. Say, suppose somebody has written CORADS 5 in their CORADS 1, and suppose patient has a benign tumor. Now, it gives a false feeling to the patient that, okay, like, you know, in general, we say, no, the cancer stage 1 is less, stage 4 is less. So CORADS 1 means nothing to be worried, I can go home. But, and also sometimes the referring clinician, if they are not aware what are we talking about, so it can create confusion. So whether CORADS 5 is more than CORADS 1, or is it CORADS 5 indicates severity, those are the doubts which, so we should remember, it only tells you the level of suspicion. It is not talking about the severity of the disease. So CORADS 4 or 5 means there is suspicion, and 5 is typical for COVID-19. So this is something we should remember. So just to give an example, so this is CORADS 1, relatively normal CT. So this is CORADS 1. Even if there is a small benign tumor, that will also be CORADS 1. And what about here? We can see some tree-in-bud opacities. So this is not COVID. It will represent other infections like TB. Now, how about here? We are seeing some patchy ground glass opacities. So it may be seen, so it's an equivocal finding, CORADS 3. And how about these two? We are seeing subpleural, here we are seeing consolidation, here we are seeing ground glass opacity. So this falls under the CORADS 4 category. And this is the typical CORADS 5, typical features for COVID pneumonia. So CORADS category to be mentioned in the report when the patient is specifically scanned for COVID-19. However, in all other patients who undergo CT scan, say for a malignancy, there's no need to write whether it is which category of CORADS, because it will confuse the patient who is seeing the report. Sometimes even to the referring clinician, it may give a false alarm, or it may not channel it to the right route. Now, just for completion's sake, I'll just mention that there are also other categories, but we are not using it commonly in India. Obviously, the British Society, they have using it more in the UK, but we are not following it. But just to note that there are also other categories. The British Society had brought out the categories of classic, probable, indeterminate, and non-COVID. Similarly, there is COVID RADS, that is coronavirus disease reporting and data system. They had brought out categories as atypical, early atypical, combination of atypical and typical. Now, I don't want to go and confuse the whole thing. So just remember the CORADS, what I have mentioned, but just know that there are also other reporting systems. Now, coming to the scoring system. Now, so scoring system, it helps you to assess the severity and extent. Now, having said that, there are mainly 4 types. Most of them actually gives the extent. Only in one of the scoring system, the severity is also addressed. So I'll just briefly tell you the different scoring system. There is 1 out of 24. Now this is very less commonly used. So I'll just say that it's just divided, the CT holds lung volume is divided into upper, middle, lower. And again, the extent is given 1, 2, 3, 4, and based on the percentage of lung involvement. Now coming to the scoring out of 25. Now, this is what is more commonly used in India. So how have they divided? So the 5 lobes, each of the 5 lobes, they have given a score ranging from 1 to 5. Now, 1 is less than 5, 2 is 5 to 25, 3 is 25 to 50, 4 is 50 to 75, and 5 is more than 75. So the maximum score for each lobe is 5. Since there are 5 lobes, 5 into 5 is 25. So depending on how much is the percentage of lung involvement, we will have the score. Now, there is also another scoring out of 40. Here, they have used the lung segments. So in each lung, there are 10 segments each. They have considered the anterior and medial basal in the left lower lobe separately, and also the apical and posterior segments in the left upper lobe also separately. So 10 segments, and in each of the segment, they have only 2 scores, either 1 or 2. 1 when it is less than 50, 2 when it is more than 50. So the maximum score in each segment is 2. Since there are 20 segments, the maximum score is 20 into 2, that is 40. Now coming to the another scoring system, the 1 out of 60, not so commonly used in India, but this is the one scoring system which also gives the assessment about the severity of the disease. The difference is, again here, similar to the scoring out of 5, it is 5 lobes which are considered. And also the lung involvement, the one difference from the 25 scoring is there is score of 1 for less than 25. Whereas in the scoring out of 25, less than 5 is 1 and 5 to 25 is 2. So now here the score of 1 for less than 25, 2 when it is 25 to 50, 3 when it is 50 to 75, and 4 when it is 75. But only difference is they have given for the lung attenuation also scores. So that gives so both ground glass and consolidation has different scores, and you multiply the lung attenuation with the lung involvement. So the maximum score possible in each lobe is 12, and that's the maximum score for the entire lung is 60. So just to give an example, so this is looking at scoring out of 25, which is more commonly used in India. So if you look at this, so it's important that whenever we do a scoring, so first of all, this is a subjective scoring. And so we should look at all the 3 planes whenever it is available, because that gives us a better idea as to how the percentage of lung involvement is. So in the right upper lobe, there is no involvement, no lesion seen. So it is 0. What happens to right middle lobe? There is 0 to 5%, less than 5%. So a score of 1. And what about the right lower lobe? It is around 5 to 25% involvement. So that is a score of 2. Now coming to the left upper lobe, so how much is it involved? It's around 5 to 25%. So again, a score of 2. Now how about the left lower lobe? This is more than 25. So it is around 26 to 49%. So that's a score of 3. So this is how we do the scoring, and then you add up. So 1 plus 2 plus 2 plus 3. That's how you give the final score. Now, there are articles which have looked and used the severity score to prognosticate the patient. And they have categorized this severity score into less than 7 as mild, 8 to 17 as moderate, and more than 18 as severe. Now, there are also articles which have told less than 7 as mild, 8 to 15 as moderate, and more than 15 as severe. Now, I will, now what happens because of this different scoring system? Now, it's very important what we are scoring, the radiologist, what we are scoring, the referring clinician should understand what it means. So if they are aware of only the scoring out of 25 and we are giving a scoring out of 60, it will not match, and it will not give the correct information what we are trying to give them. So it's important that the clinician and the radiologist should go hand in hand with what the information we are telling in the reports. So for example, so this is, I'm showing a scan with scoring done for out of 25. So we have already seen in this patient, the left upper lobe was less than 5, so score of 1. Right upper lobe also less than 5, score of 1. Right middle lobe again less than 5, score of 1. Right lower lobe 50 to 75, score of 4, and lower lobe 26 to 49 or 25 to 50%, a score of 3. And the total comes to 10 out of 25. Now the same thing, when we do it out of 60, it becomes 16 out of 60, because as I mentioned earlier, here along with the percentage of involvement, we also multiply it with the attenuation. So it is important to don't just write only the number, we should write out of the denominator also to be mentioned. And again, how the numbers changes. So here we are seeing this is patient A, this is patient B. This patient has more of consolidatory foci with some surrounding ground glass. Now here there is only ground glass. Now for the left upper lobe, out of 25 also, because it is more than 5%, it's around 5 to 25, it is score of 2. In out of 60, because it is consolidation, it comes to 3. Whereas the same another patient, because it's ground glass opacity, but the percentage of involvement is same as this patient. So in out of 25, both whether it is consolidation or ground glass, it is 2. But in out of 60, there will be difference in the scoring system. So again, this is something, so that's why I said that on the out of 60 scoring, it gives also a picture about the severity of whether it is consolidation versus ground glass. The reason being that there are many published articles which have shown that the presence of consolidation has more, the outcome is more worse in those with more amount of consolidation. Just want to highlight this particular article because this was one of the articles from where the categories of mild, moderate, severe was brought out. So this was published in European Radiology, and they have tried to use to correlate the disease severity and the short-term prognosis. And what they have found that there was significant difference in the scoring between mild versus severe, mild versus critical. And also what they have found was the survival, in the survival analysis also, they found that there is a significant drop in those with more than 18 score. And in the univariate analysis, they found hazards ratio of 8.33 when it is univariate. And in the multivariate, they found a HR score, hazards ratio of 3.74. So this shows, this was the paper which was quoted to categorize. So above 18, the outcome is on the poorer side. Now, this is another publication which has looked at the scoring out of 60. In addition to just looking at the score, they have also categorized them into whether it is subgroup 1, 2, or 3, depending on when the scan was done. So less than 5 days is subgroup 1. When the scan was done between 6 and 10, it is subgroup 2. And when it is done more than 10 days, it is subgroup 3. Now, the reason being, as we all know, the cytokine storm and the corresponding CT findings will all be higher after 5 days or after 6 days. The 6 to 11 is usually the time when the peak happens. So it is, if you are doing a CT to find the severity, then this is probably the right time, or this will give a better picture rather than doing it in the first week. Now, what they have found here was, again, there was significant difference in the scores between those who succumbed to death versus those who survived. And also in the subgroup 1, that is ones who had CTs done in the less than 5 days, the score of 14.5 was had high sensitivity and specificity for prediction of mortality. And in the subgroup 2, a CT score of 27.5 had a sensitivity, higher sensitivity for prediction of mortality. So here, if you are doing it in the second week, it is a score of about 27.5, which has a higher sensitivity and specificity for prediction of mortality. And consolidations on CT image were more common in the death group. So just to give you 2 examples, 3 examples. So this was a patient who had the CT in day 6. And this is the same patient which I showed earlier. The score was 16 out of 60. After a week, patient went home with no complications. Now, whereas this is a similar age group patient, but has comorbidities of ischemic heart disease, and though was treated adequately, patient succumbed to death, and his CT score was 34 out of 60. So as I said, this was also done at the second week. So this was, though it is in the similar age group, because the CT score was high with other comorbidities, the prognosis was bad. And also we can see presence of pneumomediastinum, and this patient was not on ventilator, but so this is also, we have often seen this happening as spontaneous. The presence of pneumomediastinum is thought to be part of valvular injury, but could also be seen in those who are on mechanical ventilation. And often we see this just an observation, as it's often they have a poorer outcome whenever it is a spontaneous. Another patient with CML, now compared to previous two patients, this patient has a lot of consolidation. The severity score was also high, 34 out of 60, and this patient also succumbed to death. So what are the advantages? It helps, the CT severity scoring helps us to assess the extent, it helps us to prognosticate, but the disadvantages is subjective. So they can be inter-observer variant. Sometimes they can even be intra-observer. Even we ourselves, sometimes we do it. There can be little bit variations, but a score of maybe within 2 to 3, we may ourselves intra-observer result, there can be some variation, and there can be inter-observer there will be inter-observer variations also. Maybe not too high. Now the question is, because of this subjectiveness, should we use automated scoring system as it is available in certain cities? Answer will be no. It is better to do the manual scoring system, because it's still not widely established or widely proven, and it's not validated fully to be used clinically. And most of the scoring systems only gives the extent and not the severity. And if you look at the percentage of scoring systems, so a 10% involvement and 20% involvement. So in terms of percentage, it's double, but the percentage comes into the same scoring system. So even though it's almost double the involvement in percentage, the same score. So there can be variations, and it may not always represent the even the extent also, because the range is quite wide. It's like 5 to 25 or 1 to 25, each of 25%. So there can be variations within that also. Now, just to show you a few of the challenging scenarios, because I know it's not always that everything is perfectly clear, that we can all rightly say, okay, this is only COVID pneumonia. Often we see there will be other things coming up also. Now, this is a patient who, a 27-year-old lady with lymphoma, finished chemo on 12th of April, was having dry cough for 3 weeks. So this was the first radiograph. We can see that there was some haziness. And then patient dyspnea worsened acutely. And that was the time when patient again came to the OPD. And then the second May chest radiograph, you can see that the haziness has become more opacified. There are also some more opacities coming up here. And by 3rd May, again, it has progressed both in the extent as well as in the density. Now, this patient, since the patient's cough has also started corresponding with the chemotherapy finishing, there was also a doubt whether there is bleomoxin toxicity or is it COVID. So we went ahead with the CT chest. Now what we saw was there are these typical organizing pneumonia pattern, especially in the lower lobes. There are also some fibrotic changes in the, in the upper lobes. But the way it has progressed from 2nd May to 3rd May, that was giving a clue that it is likely an infection. And in this present scenario, it has to be COVID. So the repeat RT-PCR was done, which came as positive. So we need to look at the timeline of how the symptoms are happening and also how the chest radiograph is changing. And then CT will also help in making the final conclusion. Now, this article has shown that there can be always co-infections happening, whether it is during COVID or even after the COVID. In this particular article, out of the 32 patients, 14 of them had co-infections. It could be viral, bacterial, or fungal. Now, this is a patient who...
Excuse me, Leena, sorry to interrupt. There are some lines coming up in your screen.
Yeah.
Can you stop? Sorry?
It's not mine. I think somebody else may be doing it.
Yeah, can you stop sharing and start resharing again? So,
Okay. Yeah, I'll do that.
yeah, sorry.
Okay, I hope it
Yeah,
is
thank you.
fine. So this was a patient who actually had a mild disease, was only on home quarantine. But after 3 weeks, patient had cough lasting for 4 weeks and breathlessness and streaky hemoptysis. That's the time patient came back to the hospital. And what we are seeing is a cavitatory consolidation, and the sputum culture grew Klebsiella pneumonia. So they are prone for other infections, either during the course or even immediately after, especially if they have other comorbidities. Now, in the similar line, another patient who had in August was COVID positive and was treated adequately. And then patient had exertional dyspnea since September and came to CMC in November. And this patient also has some occupational exposure history and has episodic cough with seasonal changes for the past 14 years. And this was the first chest radiograph. Now we can see that there are a lot of opacities, more like an interstitial changes, especially in some areas, but it is also along the periphery of the. So it's not very clear whether it is only COVID or is there something else also happening. And patient has the CT which was performed in his place. So this was the CT done in September when he started having this dyspnea. So this is immediately after his COVID infection. And so on the axial and the coronal MIP, what we can see is there are these peripheral opacities, but we can also see there are some fibrotic changes with upper lobe predominance. And so we also did CT here. Now comparing the previous CT with what was done here, we can see again that the peripheral consolidatory opacities have started becoming little fibrous, some ground glass and some tractional bronchitis have started coming in. The upper lobe fibrotic changes with some tractional bronchiectasis and atelectasis, those are still remaining. So the way in which how the upper lobe fibrosis was present even in the first CT, so there was, and with the history of occupation, we were thinking in terms of whether it could be hypersensitivity pneumonitis. So it was discussed in our MDT, and patient was started on steroids. But patient was non-compliant with steroid treatment. He was continuing for some time. Then in between, he reduced the dose by himself. And then patient started having again the symptoms, and that's when he came back. And again, we repeated the CT. And what we are seeing was the fibrosis is more or less same, maybe a little bit increase in the tractional bronchitis, but more or less same. And the ground glass opacity seems to have a little more reduced. So now this is a clear picture that the patient had COVID, but what we were seeing was not the COVID infection. It was more of an interstitial lung disease. It could be the hypersensitivity pneumonitis because of its upper lobe predominance, though not all the features are there, or it could be a fibrotic NSIP. Now, another patient who, 23-year-old with dry cough on and off for 1 year, also had fever with hemoptysis for 1 week back. Now, his symptoms is for 1 year, and then there is an acute, the fever is not very high, but had hemoptysis along with it. So because of the long-standing history, the clinically initially whether it was TB, and then the X-ray was done, which shows this peripheral opacity. So seeing these peripheral opacities, and we can also see some fibrotic changes here. So again, the question of whether there was COVID comes into the picture. And that is when we did the CT. And what does CT show? We can again see peripheral lesions. Some are consolidatory. There are some fibrotic changes, but there are more consolidatory lesions. Now, pattern-wise, we can call definitely this is organizing pneumonia pattern. Now, whether this organizing pneumonia pattern is it COVID or is it some other non-COVID etiologies, that will be the question. Now, the history of fever with hemoptysis for 1 week back, and in certain, in some of the lesions, we can see this prominent vessels going towards the opacities. That's a dilated vessel sign often seen with COVID. So then the possibility of COVID was also raised If that is ruled out, then the other etiologies. Now, his RT-PCR was actually negative, and since it was negative and symptoms are for longer duration, we wanted to look at the other cause, and TBLB was done. Now, in this case, it was interesting that patient had expert TB PCR positive, and in the bronchoscopy specimen, Enterobacter was also grown, and in the pathology specimen, there was 2 vessel thrombosis and a pulmonary infarct. Now, so then we went ahead with the CT pulmonary angiogram, and there was pulmonary embolism starting from the lobar as well as going into the segmental and subsegmental branches. And the pulmonary perfusion angiogram, which was derived from the pulmonary angiogram, also showed a relative oligemia. It was quite extensive. It was seen also in the left lower lobe and segmental branches. Now, coming to the component of pulmonary thromboembolism in COVID patients, there are various publications in it. They have looked at COVID patient versus non-COVID patients, and they found that there is a significant difference in or a higher incidence in the COVID patients. And in ICUs, again, the chances of thrombotic events are high, and majority were pulmonary embolism in this study. And in this study, they have found, again, they have matched with COVID versus from a match group from the pre-COVID era. Again, they saw a higher incidence of thrombosis. And so various studies have quoted incidence of pulmonary embolism from 6 to 30%, 6.4 to 30%. So it's a wider range, but what we should be aware is that there can be pulmonary thromboembolism in these patients, and we should be aware of it. Now, one more sign which will also help us to look into pulmonary embolism is when we see this dilated vessel sign reaching up to the consolidatory foci. So the reasons which are mentioned in the publications are whether it could be smaller pulmonary embolism, or is it in situ vascular thrombosis, or whether it is just because of the increased pulmonary blood flow, because it's an inflammatory etiology. So each of these postulates have their own post-mortem reports to substantiate them. So it is still not fully cleared out, but what we should know is there is an increased incidence of pulmonary thromboembolism, and even in patients without pulmonary thromboembolism, what the postmortem reports have shown is that they can have microthrombi in the smaller vessels. Now, this was a systematic review done in 4,410 patients, and they found the vascular enlargement in 64%. So it's quite a common finding in these COVID patients. And this is an article which has nicely detailed the pulmonary vascular manifestations of COVID-19. And they have looked at the perfusion abnormalities also in 25 patients. And what they have shown that, again, the vessel enlargement is seen in 85% of patients, either within the opacity or and also extending up to the pleura. And in the perfusion imaging, the commonest finding will be mosaic perfusion. They can also be hyperemic halo. They can be areas of oligemia, but commonest finding is mosaic perfusion. So this is the mosaic perfusion, which means that there will be areas of hyperemia, and often what is described is it will cause oligemia, which appears relatively normal looking. So there will be areas of hyperemia with oligemia, and in areas with consolidation, even this finding can be seen. That is the hyperemic halo with a reduction in the blood flow within the opacities. Now, again, I'm sure the radiologists in this group would have seen, and even the clinicians would have had a lot of post-COVID fibrotic chain patients coming for follow-up. So this is one such patient who had persisting dyspnea as well as abnormal pulmonary function test. And this was a CD done in October 13, 2020. We can see there is quite extensive fibrosis in both lungs. And the corresponding perfusion scan shows the perfusion angiogram abnormalities in terms of mosaic perfusion. Now, patient was given pulmonary rehabilitation and other treatments, and patient came back, and the repeat CT, this was how it appears. We can see that within a month, there is significant improvement in the resolution of the fibrotic changes in both lungs. And we can see that in both the coronal and axial sections. But what about the perfusion changes has not significantly changed, which shows that even when the fibrotic changes has resolved, it will take some more time for the perfusion abnormalities to resolve. So to summarize, we have looked at what is the evolving role of CT chest in the COVID imaging, its indications in both diagnosis, management, and follow-up. We have looked at the categories of COVID-19, especially the CORADs, which is most commonly used in India. We have looked at the various CT severity scoring system, and also we have looked at some of the challenging scenarios. Now, the most important or the key thing which I want to tell you is judicious use of CT is a need of the hour. So both the radiologists as well as the referring clinicians, whenever we are doing the CT, the question to be asked is, are we going to change the management of the patient based on the CT findings? If yes, then we should do it. Thank you.
Lena, that was an amazing talk.
Thank you.
So any questions? We're here for our discussions. There are a few questions in the chat box also. Pavitra, can you see the questions in the chat and coordinate?
I can read out the questions.
Yes, sure.
The Mercy, Dr. Mercy, if patient does not have any respiratory symptoms, will the CT show any abnormality?
Yeah, the answer is we can see, because I'm sure a lot of radiologists here would have agreed that a lot of incidental COVID findings we will see, and later when we do the COVID testing, they would have come positive. So they can be asymptomatic, but they can be findings. It is not that all the patients who has COVID pneumonia or pneumonia findings need to have symptoms. They can be asymptomatic also.
Sir, I don't see any more questions.
So any questions? We are free for discussions.
There is one question: ideal time to take CT for RT-PCR negative patient whose husband is RT-PCR positive. If the patient, in general, the second will be the best time. If you are going to decide if that is going to change the management, second week will be the best time. So depending on when the husband was positive, and depending on when the symptoms, and if they can do the accordingly. But again, this is not needed for diagnosis to if they have only mild symptoms. Only if it is going to decide or change the management, we should do it. Out of 60 scoring is the only one with severity. Yes, that's the only one which looks at the severity. What are the X-ray findings in SARS-CoV infection? I think that's quite a large another set of, I think the more common, I can just say a few things. I mean, I think probably another talk may be required, but the main findings are, again, it's a peripheral consolidation or hazy opacities, more in the peripheral, but they can also have peribronchovascular. The common findings are more peripheral, subpleural, consolidation of hazy opacities, and often the ground glass opacities, what we see in the CT, we may not pick up on the X-ray, it may just appear normal. So that's something we have to be aware of. So somebody, when we do the CT, it may look like the X-ray prior to just 1 day before, it would have looked normal, but we will see ground glass. Okay, there is a question: should we give CT severity scoring for post-COVID fibrosis? till how many days is CT scoring valid? I think that's a very good question. I think there's also an area of confusion, especially we have dealt with a lot of patients of post-COVID fibrosis in the first wave, and we have already started seeing from the second wave. So we shouldn't be doing a scoring ideally. There is a scoring system. The CT scoring out of 60 is originally derived from what we call the Ichikada scoring system used in the ARDS fibrosis, but that's a much complex scoring system. I think it will create more confusion. I think it's easier to tell the clinician how is the fibrosis, how extended it is it mild, moderate, or severe on a subjective basis, rather than, and we shouldn't be using this scoring. All the scoring system, what we are presently dealing with is during the active stage, when the disease is having the consolidation of ground glass. Sometimes you will see that there'll be more areas of fibrosis with small foci of consolidation still persisting. Even then, I would say we shouldn't do scoring. If the fibrosis is predominant, don't give the scoring. CT severity score, I didn't understand. Is it more than 15? Is it same for all scores? No, I think that's what I tried to tell you. For the scoring out of 25, more than 18 is what defines a severe disease, and that is the one which has been proven to have worse outcome, or mortality rate is higher in those with more than 18. This is for scoring out of 25. When it is scoring out of 60, what they have proven is, when the CT scan is done in the second week, a score more than 27.5 had a higher sensitivity and specificity for predicting mortality. If it is done in the first week, a score more than 14 has a higher sensitivity and specificity for predicting the mortality.
The questions have stopped coming.
Okay, Lina, it was a very lucid presentation. Very
There
clear.
seems to be one last question, sir.
Yeah, please.
Shall we take that?
Yeah.
GGO consolidation seen in patients after they turn negative. Do we still give severity score?
No, especially if we know, I mean, if we are seeing a GGO in CT for the first time and we are not sure when the patient was positive, then it becomes difficult. But here we know it has turned negative. That means the GGO can be as a resolving phase of consolidation. So what we are seeing is not the active phase. We don't need to give scoring. Again, if we should have the clinical picture. If you're seeing only the CT, it becomes very difficult to make that decision. Now here, the clinical picture is also there. The RT-PCR has turned negative. So that means if we have an X-ray or something prior to it, it's more likely that it would have been a consolidation, which has become ground glass, which is part of its resolving phase.
That looks like the end of the question, sir.
Okay.
Dr. Lina.
Okay, thank you so much. Thank you, Lina. Thank you, Apna. And thank you, Pavitra, for this excellent CME. Next, Nilesh. We'll go on for the next one.
Am I audible, sir?
Yeah.
Yes, sir. Now, after discussion, vote of thanks by Dr. Jalalu, sir, Treasurer, IMA Vellore.
Jalalu, sir.
Good evening, everybody. Indeed, it was a wonderful evening. We all could make use of the time and learned quite a lot about the radiological features of COVID-19. An indication for CT chest in COVID-19 and the severity scoring system by CT, the advantages and disadvantages of scoring system, and how to make use of the scoring system. Thank you, madam, Professor Leena. You are enlightened us very well. Of course, all of you will join with me to say that it was an excellent presentation. First of all, let me thank all the participants for showing a lot of interest and participation in today's webinar. An attitude like this is the motivation for us for regularly conducting this type of programs, which really help us to learn and increase our knowledge in newer diseases and also to keep us updated. Due to the lockdown and staying away from each other, we were not able to conduct any and participate in any contact programs. At least the webinars are doing a very good job. My sincere thanks to Indian Medical Association Vellore branch and Indian Radiology and Imaging Association Vellore Subchapter for organizing such an important program, an excellent program. Thank you, Dr. Madan, for spending all your valuable time and energy for IMA and especially for the COVID-19 pandemic. You're doing so many things. On behalf of IMA Vellore, we thank Dr. Kumaran and his team of IRIA Vellore Subchapter for joining us and giving full support for today's excellent program. I will be failing in my duty if I don't mention our secretary, Dr. Nilesh, for the immense amount of effort and time he has been dedicating for various programs during the COVID pandemic. My sincere thanks to Dr. Aparna Shyam from CMC Vellore for giving a detailed introduction of the program. Thank you, madam. And also thank Dr. Pavitra Mena of CMC Vellore for introducing the speaker. I will be failing in my duty if I don't mention about Dr. Narmada for the flag salutation. And lastly, our sincere thanks to everyone who participated in the lively discussion and the questions, which itself shows the interest shown by the participants and selection of the subject was very good. Once again, thank you all.
Thank you.
Thank you, sir.
Thank you, sir. Thank you all for spending your time and gaining a lot of knowledge on COVID CT. Thank you all. And I hand over to Madan, sir, to conclude.
Thanks to each and every participant who had made this program a unique one and is a successful one. I thank the IRIA team of Vellore Subchapter. Probably this is the first meeting of the new team which has taken over this year, and they have got a good number of attendance. Probably Kumaran sir, Pavitra and Aparna will do more CMEs in association with IMA and IRA. Common clinical topics can be taken, and we can have a monthly meeting also like this, which we can enlighten the clinicians on various aspects. I'll be looking forward for another meeting with you soon. Thank you, one and all.
Thank you, sir.